Alright, so now continuing on, part 2 of block 2. Just finished the first part right now. I'll wait a second for a couple people to join. Alright, let's see. And for anyone that's just joining, I will be doing streams almost every day at 12. Weekends never count, but weekdays at 12 when I'm live. It'll be in New York time. It'll be to do NBME explanations, 12 to 3. It takes 3 hours to do 50 questions. And then evening time streams, anytime after like 6 p.m. NYC time, that'll be to continue on finishing up the regular streams, like the full FA playlist stuff. So that's what it's gonna. That's the tentative schedule for now, and I'll post it on my community page on my YouTube channel as well. So number 26, a 62-year-old man comes to the physician because of pain in the left hip for 3 weeks. An X-ray of the hip shows a 4.5 centimeter destructive osteoblastic lesion with an associated fracture in the proximal femur and 2 separate similar small lesions in the bony pelvis. A needle core biopsy of the femur shows metastatic carcinoma, which of the following is the most likely primary site of the cancer. So again, first of all, we have someone that's really old, almost 65 now, right? And then it's a male, and whatever cancer this person has metastasized to the bone. So then you start looking at all the answer choices, and the most likely is prostate. That's it. Prostate cancer metastasizes via the prostatic venous plexus, which goes to the vertebral venous plexus and runs up the entire spinal column to connect to the brain through a valveless system, allowing bidirectional flow to regulate intracranial pressure. So prostate cancer can spread to the brain and lower back bones, and that's all that happened to this patient. All right? Page 712 discusses a lot of it in the end of reproductive. So when we get here, you have your BPH, prostatitis, and prostatic adenocarcinoma, which remember spreads via the prostatic venous plexus, just like I said right here. All right? System metastases may be osteoblastic, alkaline phosphatase, which is released every time you have osteoblastic activity, will be high. And this is just another UWorld question about the same thing, where the answer was prostatic venous plexus. Okay, so 70-year-old man is going to be someone over 50 for the most part. Number 27. A 23-year-old woman is brought to the emergency department because of excessive bleeding while brushing her teeth. Physical exam shows multiple ecchymoses. Lab studies show low hemoglobin, leukocyte 106, platelet count is low, and blast cells 20%. Intensive multi-drug chemotherapy is planned before this treatment is initiated. To decrease this patient's risk for kidney failure, it is most appropriate to administer a drug that inhibits or binds to which of the following sites. So, why would this patient even have kidney failure after starting chemotherapy? That's the first thing you want to figure out, right? Because then to prevent kidney failure, you're going to prevent that why thing from happening. So this patient, they're going to be starting chemotherapy, which means she has some kind of leukemia kind of stuff happening. And that is related to tumor lysis syndrome. That's how you get kidney failure. Tumor lysis syndrome is related to a lot of urea, a lot of all kinds of things that go to the kidneys and cause issues. So you would just start them on xanthine oxidase. All these other medications don't even make any sense, to be entirely honest. Allopurinol inhibits xanthine oxidase. It is used for chronic gout as well as prevention of tumor lysis-associated urate nephropathy. After tumor cells die, they release potassium and phosphate. The potassium can lead to muscle weakness and cardiac issues. The phosphate sequesters calcium, leading to hypocalcemia, which causes seizures and tetany. The phosphate and calcium make calcium phosphate stones, which damage the kidney along with the urate. Right? And all of that is actually shown with a really nice picture. Right here, tumor lysis syndrome. Right? So you see the potassium is high, calcium is low, phosphate is high. Right? The high phosphate is the reason you have low calcium, and your uric acid is high. So this branch over here is the reason you start them with allopurinol. Okay. 28. A 31-year-old woman receives a prescription for tetracycline and is instructed not to take the tetracycline with milk. If the tetracycline is taken with milk, its absorption is decreased due to which of the following effects? Now, you could just look at the answer choices and maybe pick what you think is correct, or you could remember it. Tetracyclines have a high affinity to form chelates with polyvalent metallic cations, such as ferric or ferrous iron, aluminum, magnesium, and calcium. Many of these tetracycline metal complexes are either insoluble or otherwise poorly absorbable from the gastrointestinal tract. Milk and other dietary products, antacids containing polyvalent cations, as well as various iron salts ingested simultaneously with tetracycline derivatives might interfere with their absorption. So it was really just C, formation of complex mineral ions. If you don't have any idea, it will be a little difficult of a question to answer. But alteration of stomach pH. Remember, the issue here is the only reason you're going to decrease, they tell you absorption is decreased, right? The only reason you're going to decrease absorption of something is going to be because you kind of altered it, right? So alteration of the stomach pH doesn't exactly decrease absorption, right? pH can destroy something, but it's not going to decrease absorption of something. No idea what casein is, right? Inhibition of cytochrome P450 is not related to disabsorption either. But if something makes a complex with mineral ions, you can't absorb it anymore, and that is possible. All right. So page 198 discusses that topic. Tetracyclines actually have a couple questions on NBME. So that's one thing, and they tell you do not take tetracyclines with milk, antacids, or any iron-containing preparations because you can the cations can inhibit drug absorption in the gut. That's one thing. The other thing is the photosensitivity. Everyone tends to remember that tetracyclines cause discoloration of teeth and inhibition of bone growth in children. Sure. So tetracyclines are pretty high yield on NBME itself. First thing, there's a question on some other NBME where some child that's been taking a medication for acne is now developing photosensitivity. What must she be taking? It was tetracyclines. Okay, so that was one thing. You can use it to treat acne, and they have that here. Also used to treat acne. Okay. The other thing, tetracyclines, you can give it to kids. We can't give it to them for a long time, right? Tetracyclines are actually necessary sometimes, and you can't really do much about it. And when you have to give it to a kid, you just do it, but you don't give it for a long period. Okay, so don't shy away from picking tetracycline, especially if all the other answer choices don't really fit the bug they might be talking about. And if you did sketchy micro, then you remember each one of these bugs that they mentioned here has like a bicycle wheel in the picture, and there's a couple more that aren't even mentioned here, but there's a lot of bugs that have the wheel in the picture of sketchy micro, and that wheel was the treatment. It was doxycycline, right? So the bicycle wheel. 29. A new drug has the following effects on the activity of the primary arachidonic acid metabolites produced by neutrophils, platelets, mast cells, and endothelium. And then they tell you what the effects are. So all it's doing is it's inhibiting leukocyte chemotaxis, right? It's inhibiting neutrophil leukocyte chemotaxis. No effect on platelets, no effect on mast cells, no effect on endothelium. Which of the following is the most likely site of the drug action? So you do need to remember all of your neutrophil chemotactic factors, and leukotriene B4 is one of them. The way you remember that is neutrophils come before everyone else, right? So they come before everyone else, and that would be H. So you're just stopping that, right? Page 528 discusses the arachidonic acid pathway. This question was a very different type of question on this pathway, where they're picking on a very specific branch. This patient is taking a medication that is only inhibiting neutrophil chemotaxis, and there really isn't a real medication that does that. Or maybe there is, but it's not really that common. So LB4 is a potent chemotactic molecule for neutrophils. And there's a couple other, you have to know all of them by heart. All the neutrophil chemotactic factors. And so if we do go to 528, you can see right here the leukotriene B4 is its own thing. Right? So neutrophils are B4 others, and that's how you remember that. Okay, there's a couple others, and you need to know all of them. Make sure you review that too. Discussing immunology. Number 30, a 55-year-old man with type 2 diabetes, hypertension, and hyperlipidemia develops severe myalgias with weakness. So as soon as you see that, you're starting to think like he must be taking a statin or a fibrate. Serum creatine kinase activity is increased, and urine is positive for myoglobin. Which of the following drugs is the most likely responsible for these symptoms? Such a straightforward question. The patient is probably taking pravastatin, and that's it. Right? Statins can cause myopathy, especially when used concurrently with fibrates or niacin. All right, so that's also a pretty high-yield topic for NBME. They love asking that question. 31. A 23-year-old man with a 3-year history of schizophrenia is brought to the physician for a follow-up exam. He has been taking an antipsychotic medication for auditory hallucinations, paranoia, and disorganized thinking for 2 years. Physical exam shows no abnormalities. During the interview, he does not make eye contact with the physician and occasionally turns his head when no one is talking, as if he hears someone. Lab studies show a serum sodium concentration of 120, urine sodium concentration of 8, and urine osmolality of 80. Which of the following is the most likely cause of this patient's lab findings? So anytime they mention urine osmolality, you know this is a question about diabetes insipidus. And since this patient already has some psychiatric issues to begin with, this patient's scenario is most likely psychogenic polydipsia, especially because they don't mention anything about giving the patient vasopressin or doing the water. And especially given this scenario, there's really no indication in the question for you to pick central or nephrogenic DI, right? There's just no reason for you to pick one over the other. In fact, those aren't even really per se answer choices. You know, they have some hint of it, but this is pretty straightforward, just psychogenic polydipsia. He already has psychiatric illness. He's probably just drinking too much water, and that's it. Okay. Remember that the way to evaluate that, we talked about it in another question yesterday from the same NBME, that if you do a water deprivation test and everything goes back to normal, that's psychogenic polydipsia. Because in psychogenic polydipsia, they have ADH. Everything should be fine. They're just drinking too much water, so their urine osmolality is very low. They're peeing a lot of water. When they stop drinking a lot of water, they stop peeing a lot of water too. And then central versus nephrogenic is just by giving vasopressin. If the vasopressin has activity and their urine osmolality increases because they stop peeing water, then that means that they just weren't making vasopressin, so it's central DI because the kidney responded. If the kidney doesn't respond either and the urine osmolality stays low, that means they have nephrogenic DI. They're just not making it. They're not even responding to it, okay? Pretty easy to do that. You want to make sure you understand how to really assess somebody for DI. So can't really see the picture up here, but a 51-year-old man has the acute onset of fever and respiratory failure 6 weeks after a cadaveric renal transplant. He currently takes cyclosporin, prednisone, and trimethoprim. Vital signs are high temperature, fast pulse, slightly fast respirations, blood pressure of 110. He has no rash. Diffuse inspiratory and expiratory crackles are heard. There is no gallop or murmur. An X-ray of the chest is shown, which of the following is most likely cause. Okay, so just earlier, actually, like a couple hours ago when I was doing the first part, question 25. Okay, so we'll go back and look at it. We had a similar question where the answer was Epstein-Barr virus. Here, right, atypical mycobacterium, CMV, left ventricular failure, pneumocystis, or transplant rejection. This patient must have CMV. CMV is associated with infecting organ transplant patients. CMV is transmitted via sexual contact, organ transplant, or vertically via placenta. It's one of the torches infections. Reactivation of CMV occurs in immunosuppressed patients, and he is on cyclosporin and prednisone, so he's immunosuppressed. No rash, diffuse inspiratory crackles. You couldn't really pick anything else. It couldn't be atypical mycobacterium. That would usually cause some kind of pneumonia. That's not what he's presenting with. Right. Fever, you rule out left ventricular failure. TMP prophylaxis. Put this in, right. TMP prophylaxis, you can rule out the pneumocystis jirovecii, answer choice, right? Kidney transplant, but no white blood cells or red blood cells in urine, you could rule out transplant rejection. He does not have transplant rejection. Remember how transplant rejection would present. This is not transplant rejection. A lot of people did pick transplant rejection as an answer choice. That was not the answer, though. Right? This is very evidently not transplant rejection. You wouldn't have a high fever in transplant rejection. Okay, and they didn't really give you any reason for you to really think it's transplant rejection. Okay, no Gallup lab studies, and they don't mention anything. You see urine, white blood cell, red blood cell, 0. So it's fine. But he's having high creatinine, which is fine. It can happen. But other than that, it's not really that bad. Now, question 25 from earlier, the last question, this one, the answer was Epstein-Barr virus. But this was rejection. She's having cellular rejection, and she presented with lymphadenopathy, 13-year-old. So lymphadenopathy is more of an Epstein-Barr virus thing, like mono, and cytomegalovirus was the thing for this guy, because where was it? Okay, right here. And cytomegalovirus was the guy for this guy, thing for this guy, because the others just don't make any sense. There's really nothing from any of these other answer choices that would make sense. Okay. So CMV is known to cause infection in immunocompromised people because of reactivation from the transplant. The transplanted kidney has CMV in it. A 2-year-old child undergoes resection of the right kidney because of chronic infection secondary to reflux. The left kidney is grossly normal. Which of the following structural adaptations will eventually occur in the left kidney? So many people were actually really confused when they saw this question. I mean, I can see where their confusions kind of came from, but it's also more of like how did you process the question? So basically, this guy, 2-year-old child, really, really young, right? 2 years old, not even grown up yet, lost a kidney. The left kidney is normal and it's still growing. At age 2, your kidney hasn't received maximum size yet. And not only is it still growing, now it has to adapt to practically double the amount of blood that it has to filter. Filtering occurs in the glomeruli, not anywhere else, right? Like the tubules and everything, sure, but the glomeruli is the main thing where you have everything under Bowman's capsule, right? All the glomeruli under Bowman's capsule, that's where all the actual filtering is happening, right? You filter, you send it into the tubules, then the tubules take care of stuff and make urine. That's different. So you look at all the answer choices, what is going to happen in the normal kidney? There's no reason for atrophy of tubules and glomeruli in the normal kidney. There's no reason for you to have hyperplasia of just the parietal epithelium. Can you have increase in glomerular size? Of course you can. Increase in number of glomeruli? Not necessarily. You can't make more glomeruli. That's not easy. That would require vasogenesis. But to make your current glomeruli bigger, that's possible. Metaplasia doesn't make sense either. So you're really between C and D, and you would pick C. Other kidney would hypertrophy due to increased stress. There will not be any hyperplasia because it's not about a cancer. Right? D is hyperplasia. The number of glomeruli increasing, that's kind of like hyperplasia. You would have hypertrophy, right? Always think of hypertrophy versus hyperplasia. Always think of like the heart, right? The heart always does hypertrophy. You can't make more heart cells. You're either going to have dilated cardiomyopathy or hypertrophic cardiomyopathy. You'd never have hyperplastic cardiomyopathy. That's not a thing. Right, so hypertrophy is the thing that happens when you have increased stress. So if any organ has increased stress, it will hypertrophy, which means it got bigger in size. Atrophy is getting smaller in size. Hyperplasia is making more cells, and that's cancerous. Okay. 34. A 3-month-old boy is brought to the physician because of facial abnormalities and weakness since birth. Physical exam shows coarse facial features and hypotonia. Urinary excretion of mucopolysaccharides is within reference range. The concentration of lysosomal enzymes are increased in serum and decreased in cultured skin fibroblasts. Which of the following molecular markers is most likely decrease in this patient's lysosomal enzymes? Okay, so first thing you need to figure out was what's actually wrong with this kid, right? Sounds like a lysosomal storage disease. So facial abnormalities is a pretty unique thing though. You don't really see facial abnormalities in all the lysosomal storage diseases. You actually end up seeing it in only one thing, and that's going to be, I believe, in one of the last two, Hunter or Hurler. I think both, Hunter and Hurler. Yeah, they both have facial abnormalities. Physical exam shows coarse facial features, right? Hypotonia. Now, urinary excretion, they said, is in normal range, but the concentration of lysosomal enzymes is increased in serum. But there aren't that many in the skin fibroblasts. What must be which marker must be missing? And then you start looking at all the markers, you kind of realize that all of these aren't really not related to something you can think of except for mannose 6-phosphate. Mannose 6-phosphate is related to eye cell disease, which actually does have gargoylism, which is what they're describing by coarse facial features. Right? Eye cell disease is a mucolipidosis lysosomal storage disorder, where you have a defect in N-acetylglucosamine 1 phosphotransferase, causing a failure of the Golgi to phosphorylate mannose residues. So you don't have any mannose 6-phosphate, you would just have mannose. You can't phosphorylate it. You can't phosphorylate the 6th area. Proteins are going to be secreted extracellularly rather than being delivered to lysosomes, and then you get coarse facial features, gingival hyperplasia, clouded corneas, and so on and so on. When you go into metabolism and you look at the lysosomal storage diseases, you get a similar kind of thing happening there too, and obviously these are very high yield and you should master them. Hurler and Hunter both have gargoylism. Right? See, Hunter is a mild hurler. You're going to have gargoylism here too, but not as much, except these guys are related to heparin and dermaton sulfate, so that wasn't even one of our answer choices. As far as these guys are concerned, none of these guys have coarse facial features, so you don't even need to worry about it. Okay. Number 35, an 83-year-old man is brought to the emergency department after being found at home bedridden and confused. 83, so very, very old. He takes no medications, temperature is 96 Fahrenheit, pulse is 100, blood pressure is pretty low, blood pressure is unchanged after IV infusion of isotonic saline. A pulmonary artery catheter is inserted and the following findings are obtained. Cardiac output is high, PCWP is low, systemic vascular resistance is also low. Which of the following is the most likely cause of the hypotension? Okay, so since PCWP is low, you know that this is not because of the heart itself. It's not the heart that's causing something to occur. So where is it happening from? Why is this guy's issue like this? Well, it could be septic shock, GI bleeding, hypothyroidism, pulmonary embolism, silent MI. All of these are actually answer choices where you could possibly have hypotension. Okay, but then you have to remember the data they gave you, right? Cardiac output is high. Which one of these guys would have high cardiac output? Well, if you have a GI bleed, you just lost blood, so you're not going to have high cardiac output. If you have hypothyroidism, you're not going to have high cardiac output. You're probably going to have low cardiac output. Hyperthyroidism can have a higher cardiac output. A massive pulmonary embolism will also not have a high cardiac output. If you have a pulmonary embolism, that's going to be pretty painful and you're not going to be breathing fine. There's going to be many other presentations. You're not just going to be bedridden and confused, first of all. Right? So they don't even describe a patient right now who looks like they had a pulmonary embolism. So that goes away. A silent MI. Okay, doesn't matter if silent or not. If you have an MI, you're not going to have a high cardiac output. So that information in the middle alone helps you pick early septic shock where you could have high cardiac output, right? And again, they're loving their shock questions, right? We revisited this table, like this is the third time I'm coming back right now. This is the third question about shock on NBME 20. Right, so this guy right now is having shock, right? Septic shock, which is basically distributive shock, and this is described down here, right? Distributive shock is a collective term for shock that results in pathologic vasodilation leading to a decreased systemic vascular resistance, which is what our patient has. The most common etiology is septic shock, but it can be also due to neurogenic shock, where cardiac output and heart rate would be low, or anaphylactic shock because of some kind of allergy. Circulating cytokines and bacterial toxins cause pathologic vasodilation and lead to decreased afterload, as well as decreased central venous pressure and decreased PCWP. Consequently, there is an increase in heart rate and cardiac output, which we see. Patients with septic shock will often have warm, flushed skin as a result of this pathophysiology, and you need to give them vasopressors and epinephrine if it's anaphylactic. Okay. So that's what this patient's having, and that's it. Really, really not that bad. Even if you didn't quite know, you could just look at each answer choice and evaluate the presentation and see if it kind of falls into place, and that's it. 36. In patients with breast cancer, metabolically stable agonists of gonadotropin-releasing hormone are effective because they inhibit the release of which of the following. So this is a question literally about leuprolide, right? If you think of an agonist of GnRH, gonadotropin-releasing hormone, that's leuprolide. What does leuprolide do? Well, if you give medication, right, in patients with breast cancer, I'll come back to it. If in patients with breast cancer, metabolically stable agonists of leuprolide are effective how? So how does leuprolide work? Well, GnRH agonists like leuprolide are effective for patients with breast cancer because if given in a continuous fashion, they downregulate the GnRH receptor in the pituitary and ultimately decrease FSH and LH, which is answer choice B, gonadotropin by the pituitary gland. And it really made a lot of sense, but at the same time, I can see how people would shy away from it. Think of it. If you're giving somebody GnRH, you're going to increase gonadotropin from the pituitary gland, and that's going to be really problematic, right? So a lot of people wouldn't pick B. You get what I'm saying? Like, GnRH is gonadotropin releasing hormone, and I'm giving an agonist of it. So then what would happen? Well, you would have gonadotropin release, so you're not going to pick answer choice B. But that's not what's really happening. By giving GnRH, you actually downregulate the GnRH receptor. So you end up having a decrease in gonadotropin, and that's B. That is the correct answer. A lot of people went with picking prolactin because they mentioned breast cancer, and that was just, them baiting you. Don't get baited. Do not get baited. You need to know how things work. This is also the same way alcohol works too. With chronic alcoholics, a lot of the receptors get downregulated and a lot of receptors get upregulated. GABA and NMDA, those are the two receptors. You have to remember which one gets downregulated, which gets upregulated. And because of that, when they stop drinking alcohol, they end up having a lot of issues. GABA gets downregulated, and without the GABA stuff, they keep having their tremors, and the NMDA stuff gets upregulated, so they get that seizures and all of that stuff as soon as they stop the alcohol, and withdrawal symptoms kick in, right? So you need to know that giving an agonist of something that is related to hormones, right? That's the trick of endocrine. When you give a hormone releasing hormone agonist, something that comes from the hypothalamus, something that comes from the brain. When you give a releasing hormone agonist, you end up messing up everything downstream. Your body will stop showing receptors for it because there's too much coming, right? Your body can't stop you from releasing more of it, but it can stop using more of it by showing fewer receptors, right? So that's what your body's going to do. It's going to show fewer receptors. And if you look at leuprolide 714 in reproductive form, where did I click? Oh, 724. 714 leuprolide. So you can see here your hypothalamus, right? Leuprolide, GnRH analog with agonist properties when used in a pulsatile fashion, but it has antagonist properties when used in a continuous fashion because it downregulates GnRH receptors in the pituitary. So if you give it in a continuous fashion, your pituitary is going to be like, yo, there's way too much GnRH. Let's stop showing so many receptors so that we can use fewer amounts of the GnRH. And then you have a downregulation of both FSH and LH, and that helps. It's mainly used for uterine fibroids, endometriosis, precocious puberty, prostate cancer. They didn't even mention breast cancer here. So it's kind of messed up of NBME to ask you a question regarding breast cancer for the most part. But it is what it is. UWorld tells you another thing regarding flutamide, so you need to know that too. Leuprolide is pretty high yield in UWorld, and like most Q banks do, it's on Amboss too. Initial use of leuprolide will cause a transient rise in pituitary LH secretion, which leads to a rise in testosterone levels. However, continuous use suppresses LH release and leads to a decrease in testosterone levels. With lesser testosterone, there will be lesser DHT production as well. To counter the initial transient rise of gonadotropins, adjunctive therapy with flutamide can help counteract unwanted effects. For example, a woman taking leuprolide might have high amounts of DHT early in the use and might end up having hirsutism or something. So if you want to, if you don't want that at all, you can give flutamide as well. And that's really all there is to it. So it's a pretty high yield medication, really important to make sure you know how it works, and keep in mind that the continuous use is to inhibit gonadotropin release, even though it is a gonadotropin releasing hormone agonist. Continuous use makes it an antagonist. Back here, the hypothyroid answer choice. Yeah, hypothyroidism is like being fat and slow, right? That's what you have to remember, the whole profile of a hypothyroid patient. Hypothyroidism also, thyroid hormone is directly related to beta-1 receptors, right? So if you have hyperthyroidism, you will work on beta-1 receptors. You're going to increase heart rate. And hyperthyroid, like thyroid hormone, is like it's almost like the good steroid of your own body. It's kind of like being really, really strong. If you're hyperthyroid, you have a lot of muscle mass, a lot of power. You can increase cardiac output. Hypothyroidism is the opposite of that. You don't have thyroid hormone, so you're not that strong. Everything slows down. Metabolism slows down. Heart rate slows down. They get cold easily, right? There's a lot of stuff like that. So a hypothyroid patient would have a low cardiac output or a normal cardiac output, but not a high cardiac output, especially in an 83-year-old patient. You want to keep in mind, someone above 65 again, right? An 83-year-old patient should not have high cardiac output. There's really no reason to, right? He's not working out. He's not really doing anything strenuous. He just has hypotension with a high cardiac output. As a doctor, you immediately think of septic shock. Anyone with hypotension and cardiac output that's high, septic shock, and you're done. That's it. Okay. Number 37. 37 says a 62-year-old man comes to the physician because of a 1-week history of muscle cramps accompanied by painful spasms in his arm and legs. He tells the physician that for the past 4 months he has had trouble opening jars and using silverware. Examination shows muscle weakness and exaggerated deep tender reflexes. An appropriate treatment of the muscle cramps and spasms in this patient includes systemic administration of a drug with which of the following mechanisms of action. Okay, so this patient, exaggerated deep tender reflexes is a upper sign, right? So something that's high, like an upper motor neuron thing, and appropriate. So other than that, it doesn't quite look like he has Parkinson or Huntington or anything like that. They only described enough things in this question to make it look like an upper motor neuron lesion. That's basically it. Muscle cramps, painful spasms, yeah. So exaggerated deep tender reflexes. You have to remember, we're not done with neurology yet, but always remember everything is up in an upper motor neuron injury and everything is low, including the Babinski sign, right? There's no Babinski sign in a lower motor neuron, but your toe goes up in an upper motor neuron lesion, so that's also a positive Babinski sign in an adult, and that's not normal. So this is just an upper motor neuron lesion. He's having difficulty stopping, so you need an agonist at GABA receptors. That's it. Right? This patient likely has some form of upper motor neuron lesion. Upper motor neuron lesions are characterized by weakness, increased deep tender reflexes, and spastic paralysis. Spastic as opposed to flaccid. Flaccid paralysis is just you're just falling. Spastic is like clasp knife, like you're pretty stiff. Baclofen is a GABA agonist specific to the spinal cord, used to treat muscle spasticity, dystonia, and multiple sclerosis. GABA B is a G protein coupled receptor coupled to GI, so inhibitory. So agonism of this receptor causes hyperpolarization of neurons and decreased release of excitatory glutamate. That's it. Okay. 38. A 62-year-old woman comes to the physician because of progressive bilateral lower abdominal pain and distension during the past month. Pelvic exam shows an adnexal mass on the right. Pelvic ultrasonography shows a right ovary with an internal echo pattern highly suggestive of ovarian cancer. Microscopic exam of the peritoneal fluid obtained by paracentesis shows malignant cells. Yeah, I get it already. She has some kind of cancer. Paclitaxel is initiated. This treatment will target which of the following in this patient tumor. Paclitaxel and taxanes in general are pretty high yield in NBME too. If you look at all the NBMEs that came out, like 2021 and 22 is what I've looked at, they keep having a question about this one. Like every one of them had it so far. And paclitaxel is a taxane that works at beta tubulin. Right? Remember that taxes stabilize society, and understand that this paclitaxel stabilizes the M phase. Beta tubulin is a subunit of tubulin. Tubulin is one of the several members of a small family of globular proteins. It is the major constituent of microtubules. There are two of most common members of the tubulin family, alpha tubulin and beta tubulin, and together their dimers form microtubules. So paclitaxel is a microtubule inhibitor, page 475, and basically it stops you from moving on to anaphase. Okay, so you're not going to go into anaphase, and I put that, yeah, paclitaxel and other taxanes, right? Hyperstabilized polymerized microtubules in the M phase, so you cannot go into anaphase. Anaphase cannot occur, so cells will be stuck in metaphase. I always remember that as the M phase. It's not what the M really stands for, but just keep that in mind. Okay. Ovarian and breast carcinomas. That's it. You can get myelosuppression for pretty much all the medications in this chapter. So that's really all this question was about. Just whether or not you remember. That's all that question was about. 39. A 19-year-old woman has severe refractory pustular acne that has been unresponsive to several topical and systemic therapies. Treatment with daily oral isotretinoin is begun. Which of the following pharmacologic effects of this drug is dependent on its binding to the RXR receptor? And if you've never heard of the RXR receptor, then you need to look into it. When I was studying for my step 1, USMLE RX talked about it. USMLE RX talked about it a lot. Step 1, first aid doesn't really talk about it much actually, and I don't even know where you can hear about it now, but you can definitely find more about it on YouTube. So page 66 discusses isotretinoin and vitamin A. Remember isotretinoin, because remember it is a teratogen. You need to be on at least 2 forms of birth control if you're taking it. Isotretinoin is used to treat severe cystic acne. It is a teratogen, can cause multiple severe birth defects. Contraception is mandatory, and RXR is retinoid X receptor. The answer here was D, teratogenic effects in the embryo. Alright, so which of the following pharmacologic effects of this drug is dependent on its binding to the RXR receptor? It was D. Such a weird way to bring this up, and a lot of people would have no idea what they're really talking about if they've never heard of it, but the RXR receptor and the teratogenic effects in the embryo are related, and that's how the pharmacologic effects kind of work. It's dependent on it. You can't have the effect of isotretinoin if you don't let the teratogenic things happen. So since you have to let teratogenic things happen, you have to make sure that the patient doesn't get pregnant, or there will be teratogenic effects. Alright? 40. Let me see. I can't remember if I have anything. No. Okay. Yeah, but in the book though, they don't really talk about the RXR stuff. Okay, so you have to make sure you look it up. It is a very big deal related to vitamin A and isotretinoin usage. Alright, number 40. A 54-year-old woman with terminal metastatic pancreatic cancer comes to the physician for a follow-up exam. She asked the physician to prescribe her a sufficient quantity of medication to allow her to commit suicide if the pain becomes unbearable. The physician refuses to do so, but he informs the patient that he will do everything he can to manage her pain. The physician's decision in this situation is most consistent with which of the following ethical principles? Okay, this is a very common thing, right? And it's actually a very controversial thing in America. In Florida, a lot of things have been happening where a lot of physicians are kind of, letting this happen, and they help with the suicide. The assisted suicide is becoming a thing, but then people are ethically arguing back that it should not have been a thing. You should have helped the patient, and blah blah blah. So a lot of battling is going on regarding these things. But in general, for this specific question, the patient with metastatic pancreatic cancer is asking to be allowed to commit suicide. Metastatic pancreatic cancer is pretty much a sign that you are going to die, right? Very few people survive after being diagnosed with pancreatic cancer, let alone metastatic pancreatic cancer. So there's no point in helping this patient commit suicide. She's going to die soon enough anyway. And remember, with any patient that's about to die, no matter the age, you do everything you can to maintain their comfort, right? And that was E, non-maleficence. You're not going to do something that's bad for the patient. That's it. A lot of people were actually thinking beneficence. Some people thought it was autonomy. It's really not any of it. The question is very vague. Right? There's no arguing. It's a very vague question. It is easily arguable that this is beneficence, in which the doctor is acting out of what is best for the patient, but also against the autonomy of the patient. But remember that the patient's interest supersedes. This is non-maleficence. The doctor must do no harm, and this has to be balanced with beneficence, so the benefits must outweigh the risk, and the patient must make an informed decision. The main thing that makes this question not so vague is remembering the fact that the patient is going to die. If this patient was not if this patient was not suffering something where they're going to die, then it'd be a whole different thing. Then suicide is an actual, if the patient wants to commit suicide, now you got to evaluate, are they psychologically okay? Is there any kind of valid reason for them wanting to commit suicide? Okay, but if they're already about to die as it is, helping them commit suicide would not be a thing. Help them cope with the pain, even if it means giving them the worst pain medications ever, the most addicting pain medications ever. None of that matters, because addiction is not an issue if you're about to die. All right, so that's what's happening here. And these principles often seem, when you read them, you might be like, all right, I'm a boss at it. I know exactly what's happening with them. But then you get questions that can really mess things up. Okay, autonomy, obligation to respect patients as an individual, create conditions necessary for autonomous choice by not judging them, not threatening them, right, and keeping everything open, and to honor their preference in accepting or not accepting medical care. Nowhere here does it say that you would be okay with letting them ask you to help them commit suicide. Beneficence. Physicians have a special duty to act in the patient's best interest, may conflict with autonomy, or what is best for society. Traditionally, patient interest supersedes. However, with our patient, what's in his best interest is no longer stable because he's about to die. What would be in his best interest would to keep him alive for as long as he can, but not in pain, right? Because then that's torture. Non-maleficence is do no harm, which has to be balanced against beneficence. And if the benefits outweigh the risk, a patient may make an informed decision to proceed. Right? Most surgeries and medications fall into this category, but suicide is under the physician's options. Right? Physician is the one that picks that, not the patient. I mean, if the patient is going to go commit suicide in any other way without the physician's help, that's different. But as far as the physician's help is being asked, the physician is the one that makes the call on that, and you should generally say no, always. Never say yes. 41. 22-year-old woman comes to the emergency department because of a 2-hour history of fever, chills, and muscle aches. 6 hours ago, she received an injection of penicillin G, benzathine, for syphilis. Her temperature is 102. Physical exam shows nothing. What explains her findings? And that is something that's a very straightforward way of asking you a question about Jerax-Herxheimer reaction. So it's going to be D, a release of bacterial products. When they mention syphilis and penicillin, and now you have some kind of flu-like symptom, really, that's like, it's the classic way of asking you a question about that. There's no other way to really test you on this. Super straightforward. Very nice question. Penicillin is the only treatment, by the way, for syphilis. So if a patient comes to you and they tell you they're allergic to penicillin, you still give them penicillin. You would desensitize them to the penicillin, then give them penicillin the best you can. But there's really nothing else you can give for syphilis. And then when the syphilis, those treponema, when they die and they rupture, they release all their stuff. It's like a suicide thing. Like, all right, I'm going to die, but before I die, let me hurt you as much more as I can. Okay, so that's what the Jerax-Herxheimer reaction is. They tell you about it on page 150, right after syphilis. Jerax-Herxheimer reaction. They talk to you all about syphilis, a shit ton of stuff, right? These are treponemes and flu-like syndrome, fever, chills, headache, myalgia. After antibiotics are started, this is because the killed bacteria release toxins. All right, so the spirochetes are a big problem. Couldn't really pick anything else. A flu-like reaction would not be an antibiotic resistance. It would not be drug allergy. Antibiotic resistance would mean that the penicillin didn't work, but then syphilis doesn't cause flu-like symptoms, so that wouldn't make sense. A penicillin G drug allergy is also not a flu-like symptom either. DIC doesn't present like a flu either. DIC would have hypercoagulation all over her body. And serum sickness and DIC are pretty similar because you run out of stuff. Serum sickness would just run out of complement, and that's also not what's happening here. So that's it. It was a very classical question. 42. This is a pretty high yield thing. So an 18-year-old woman comes to the physician because of fever, severe sore throat, and fatigue. Temperature is 100.6 F. Physical exam shows pharyngeal erythema, lymphadenopathy, splenomegaly. Lab studies show leukocyte count of 4,400 and 20% atypical lymphocytes. Which of the following cell types most likely accounts for the atypical lymphocytes? So mono is a common thing. And if you have an 18-year-old girl, right, that's a teenager, she's been kissing men, she's going out, she's doing that, she's having a good time, and Epstein-Barr virus is going to cause mono in her, which is very clear because she's presenting with lymphadenopathy. The lymphadenopathy was the giveaway part for mono. And Epstein-Barr virus infects B cells, right, through CD21, but the atypical lymphocytes in Epstein-Barr virus are actually reactive T lymphocytes. You have to remember that. This is a topic discussed a lot by UWorld, by me. I talked about it like a shit ton of times already. So you see Epstein-Barr virus, they'll give you an image like this, right? And this is a reactive lymphocyte. This is a normal lymphocyte on the left. If the question is about Epstein-Barr virus and they ask you what this weird lymphocyte is, that's a reactive T lymphocyte, right? Not an infective B cell, but rather a reactive cytotoxic T cell that's trying to kill the virus. But the B cells are infected, and being infected doesn't make the B cell look any different. It's just infected. That's it. Now, later on, you get PCNSL, right? Primary central nervous system lymphoma. A primary central nervous system lymphoma can have the same exact image. Over there, it's actually an infected B cell, the one that looks like this. Okay, so really important to know that. So on Epstein-Barr virus, the messed up looking lymphocyte is a reactive T lymphocyte. In primary central nervous system lymphoma, if I give you the same exact image, and I'm talking about the PCNSL, not the Epstein-Barr virus, if I'm talking about the PCNSL and I ask you what this is, that is a lymphoma B cell. It's an infected B cell. Okay? But pathogenesis does involve Epstein-Barr virus. There's some overlap, so make sure you're careful about making sure what the question is actually asking you about before you pick an answer. Is it asking about the lymphoma or the Epstein-Barr? In Epstein-Barr, this guy is a reactive T lymphocyte. With the lymphoma, this guy is actually an infected lymphoma B cell. Alright, so that's the difference there. Really important to make sure you know that. 43, 2 days after admission to the hospital because of drug-induced thrombocytopenia. So drug-induced thrombocytopenia, that should ring a bell too. A 37-year-old woman develops a severe headache and becomes comatose. On admission, examination shows a few petechiae over the lower extremities, and her platelet counts was 5,000. A CT scan of the head shows an intracranial hemorrhage. A platelet transfusion is recommended, but the patient is a Jehovah's Witness and had stated on admission that she did not want to receive transfusion of any blood products. Her husband is not a Jehovah's Witness and wants her to have the transfusion. Which of the following is the most appropriate management regarding transfusion? Fuck that. No one cares what her husband is. This is a grown-ass woman that told you she doesn't want any transfusions. So you don't give it to her. That's it. Do not proceed with the transfusion. The only time you transfuse a Jehovah's Witness is when the patient is a minor, because the minor might not be a true follower of the religion. And that's it. You gotta save the life of an infant no matter what. You gotta save the life of a minor no matter what. Adults make their own decisions. And if this 37-year-old woman told you herself she doesn't want any transfusions because she's a Jehovah's Witness, and then she passed out or she's comatose or whatever, it doesn't matter. She's made it very clear what she wants. That doesn't change if her mental capacity goes away later. Because when she said it, she was under the right mental capacity. And what her husband wants has nothing to do with it. You know, I mean, sure, you could hear him out, but his consent or his anything is not necessary. She's already made her decision about her medical care before going into a coma. Right? So if anyone has any questions on this one, or if they feel like it should have been another answer choice, definitely feel free to reach out to me about it. I know a lot of students were, confused. I mean, some people really felt like this is a scenario where you would need the ethics committee. 99% of the chance you do not get the ethics committee. So that's almost never the answer. Consent from the patient's husband or the patient's minister doesn't make any sense. It's not about them. It's about the 37-year-old woman herself. Proceed with the transfusion without consent would never be the correct answer. You can't do that in America. Everything in America is with consent. Right, so just do not proceed with the transfusion because she's already denied consent. She's already said, don't do it. Right? So that's it. 44, you get this gross image, right? And it is looking pretty gross. And 18-year-old woman. So you can see a lot of polyps already. 18-year-old woman, which is really young, comes to the physician to request screening for colon cancer. Her father and grandfather died of colon cancer at ages 36 and 45, which is really, really young. And you can notice something. 36 and 45, that's only 9 years apart, which is about 10 years. So it looks like something's happening, right? Physical exam shows no abnormalities. Colonoscopy shows 200 lesions throughout the colon. That many polyps is FAP, right? Familial adenoposis polyposis. A colectomy is done and the section of the colon removed is shown. Which of the following is a chance that this patient's offspring will develop the adenocarcinoma of the colon? So, FAP is an autosomal dominant mutation, right? So is Lynch. Thousands of polyps arise starting puberty. Pancolonic always involves the rectum. Prophylactic colectomy or else 100% progression to CRC. Autosomal dominant diseases have a 50% chance of being passed off to the offspring, and that's what you would pick. Alright? But a lot of people were confused and picked 100% because they remember the 100% colon cancer, but that's not what we're talking about here. That's not genetics. That's statistics. That's like, yeah, if you have FAP, you're probably going to get a colon cancer no matter what. Like, it's guaranteed, so you just remove the colon. 50% though is autosomal dominant. And that's it. Page 59 discusses inheritance. 420 discusses FAP. So let's actually take a look at the 420 stuff real quick. Right, familial adenomatous polyposis. This one. Autosomal dominant mutation of APC. Tumor suppressor gene on chromosome 5. Right, because polyp has 5 letters in it. 2-hit hypothesis, because the tumor suppressor, thousands of polyps start after puberty. Pancolonic, always involves rectum. If you look at Lynch, this patient, what they had could also be Lynch, previously known as hereditary non-polyposis colorectal cancer, autosomal dominant mutation of DNA mismatch repair, 80% chance to progress to CRC. The proximal colon here is always involved. So Lynch is proximal colon, whereas FAP is the rectum. The rectum is always involved. The only difference is though Lynch syndrome has multiple things. It also has endometrial, ovarian, and skin cancer. And since they didn't mention any of that, this must be FAP. Everyone just had colon cancer. All right. 45. A 41-year-old woman with systemic lupus is scheduled to undergo surgical placement of a peritoneal dialysis catheter. The surgeon asked the resident physician to get the consent form signed the evening before the procedure. The resident has never seen this procedure performed and has read little about it. So basically, he hasn't read about it. Remember, whenever you tell someone, oh yeah, I've read a little bit about it, that basically means you didn't read it. You didn't read it enough. You don't know enough. He will not be assisting with the procedure either. Which of the following actions by the resident physician is most appropriate? Well, if you don't know shit about the procedure, you've never seen the procedure being done, you're not that confident about the procedure, you can't go ask somebody else for consent about the procedure because you have to tell the patient so much about it as if you know everything about the procedure. So the correct answer is B. Ask the attending physician themselves to go obtain the informed consent. There's nothing wrong with that. You don't need to feel bad doing it. It's not something asshole-ish or whatever. It's the correct thing to do. Informed consent should be obtained by a provider who has sufficient knowledge to give accurate description of the intervention, the risks, the benefits, and able to answer all patient questions. Okay? So if you didn't read enough about it and you've never seen it being done, you wouldn't know so much. Right? It's really important to make sure you know that. Informed consent is a really big deal. Hospitals get sued if they don't do it correctly. So informed consent, right? Exceptions to informed consent are WIPE, right? Waiver, because the patient doesn't want to talk about it. So if the patient tells you, hey, don't ask you for permission to do what you need to do, you don't ask. Legally incompetent, because the patient lacks decision-making capacity, which basically means that they might be too drunk or something. Therapeutic privilege, where you're withholding information when the disclosure would actually harm the patient. And emergency, so you get implied consent, okay, like the patient might be about to die. That's about it. Patients must have an intelligent understanding of their diagnosis and the risk benefits of proposed treatment and alternative options, which means, including no treatment, which means intelligent, right? So that means that if the patient doesn't speak English, you need to get them someone that does speak their language to give them all the informed consent information. You can't get informed consent from someone if they didn't understand every single word you used. Patient must be informed that he or she can revoke written consent at any time, even orally. So if a patient signed a document consenting to a certain surgery, and then a minute before the surgery, they're like, you know what, I don't want this anymore, they can say that, and you would stop the surgery. There's nothing wrong with that. You're still going to get paid for the surgery, so you don't care. If anything, you just saved yourself mad time, and the patient just leaves, and that's it. That's the end of that. So make sure you remember all of that. It's tiny things that you might think you understood very well until you see it in the question. Then you're like, shit, I don't remember anymore. This was pretty cool. This is pretty interesting. Not too bad. This one said, 23-year-old man comes to a physician because of a 1-month history of weakness and muscle pain after exercise. So that should immediately remind you of like McArdle maybe. His mother, sister, and grandmother have similar condition. However, his father's sister and her children are unaffected. A muscle biopsy shows ragged red fibers. So now you're like, oh, ragged red fibers. Okay, so it's like some kind of mitochondrial myopathy. This condition most likely results from a mutation in a gene located in which of the following labeled structures in the photomicrograph. So they're just asking you which one of these is the mitochondria. So if you look at each one, A can't be the mitochondria. It doesn't have the stuff inside, right? It's too empty. B could be the mitochondria. It has the stuff inside. Okay. C, definitely not a mitochondria. That's a skinny little thing in the middle. D is pointing at these other things that are definitely not mitochondria either. And E is pointing at the black things, which are also not mitochondria either. Okay. There's a video on YouTube. I'll post the link here too. This one is a really nice video showing you the electron microscopy of organelles. So if you have any trouble understanding that, you can check out this video. It's a pretty nice run through of identifying
First off,
parts.
you can differentiate between the smooth.
She has a really nice UK accent thing going on too, but yeah, she helps you kind of really see everything, you know, and you can really get a good eye for understanding where things are, because it is very likely that you can have at least one question where something like this pops up. So you see how mitochondria have the shoelace kind of thing always. So you have to remember you're looking for that. That's generally it. So that's that. 47. A 45-year-old woman develops proteinuria and hematuria. She has taken 3 grams of ibuprofen for headaches almost daily for the past 2 years. So that's long-term NSAID use. Which of the following findings is most likely in tissue obtained on renal biopsy? Okay. So on one of the pages at the end of renal pathology, they talk about all of these: AIN, ATN, DCN, and RPN. I'll show you. This patient, who's been taking ibuprofen and is now presenting with acute interstitial nephritis due to the NSAID acting as a hapten and inducing an IgE-mediated type 4 hypersensitivity. That's what happened to her, because she has proteinuria and hematuria. That is interstitial nephritis, proteinuria and hematuria. The 5 Ps remind you of the medications that can cause this, but it can also be secondary to lupus or autoimmune disease. ATN is acute tubular let's actually go to it. Nephritis, and in that one you're going to see different things. 657. I'm going to say AIN. That's the one. Ps, so diuretics, pain-free, penicillins, proton pump inhibitors like omeprazole and rifampin. This is an AIN is an IgE-mediated type 4 hypersensitivity. All right, so you got to make sure you remember that too. It's not mentioned in first aid. ATN is acute tubular necrosis, not nephritis, sorry, acute tubular necrosis, and necrosis has slowing of things, right? So you can see images A and B, you get the muddy brown appearance of granular casts, and then you can have tubular cells that die and slow off into the tubular lumen. Inside the lumen, you have cells dying in there, all right? So this is usually going to be someone who's hospitalized and has an oliguric phase where they are not urinating. That has to be given to you. Can be fatal. There's the inciting event, the maintenance phase, and then the recovery phase. And the recovery phase is polyuric. They're going to be peeing a lot all of a sudden. BUN and serum creatinine fall back to normal levels, but there's a risk of hypokalemia and renal wasting of other electrolytes. Right, so the recovery phase, though, is where you reepithelize your tubules. Everything's being fixed up. ATN can be ischemic or nephrotoxic, and based off of different things, that's how you have to figure out what happened to a patient. When you're studying this, make sure you also look at the segments. So ischemic stuff is usually the PCT and the thick ascending limb, because those are susceptible to injury. Nephrotoxic things can be almost anywhere, so that's different. Right? Proximal tubules are particularly susceptible to nephrotoxic things. And remember, your PCT is where you kind of reabsorb everything, so you're going to lose everything. DCN is diffuse cortical necrosis, necrosis of the cortices, and this is usually because of DIC. So that's only going to be one thing: DIC, septic shock. Renal papillary necrosis also is related to long-term NSAID use, right? But this is not going to have hematuria and proteinuria necessarily. You're going to have gross hematuria and proteinuria, right? It's not just going to be like cells or stuff. You're actually having necrotic renal papillae slowing off. So you're going to see big amounts of blood, not just like basic hematuria. So they'll describe that to you, and that's when you pick papillary necrosis rather than interstitial nephritis. Right? So you need to make sure you study this page really, really clearly. Make sure you understand it. Make sure you know where the differences between all of these are. No, this one is this is it's type 1 is antibody. This is not antibody per se. IgE mediated hypersensitivity, it's not exactly an antibody attacking something, so it's different from that. If you go back to where did they talk about that? immune responses, right? Yeah, so if you look at type 1 is going to be something with an allergen, right? Allergen specific for IgE is not the part that you pick it. It's not, type 1 is just an allergen. So that's how you pick type 1. The IgE here is not what makes it allergens, it's the allergen itself. Sorry, the IgE is not what makes it a type 1 hypersensitivity, it's the allergen that makes it a type 1 hypersensitivity. For type 2 is the allergen and the antibody, right? Or the antigen and antibody. Type 3 is going to be complex as well, and type 4 also has things that have to do with allergic things, but it's delayed as fuck. And you could tell it's really delayed with the AIN because that patient, for example, was taking NSAIDs for over 2 years now. Right, so the IgE stuff isn't what makes something type 1. It's the allergen that makes something type 1. That's how you figure out something is type 1 hypersensitivity. Alright, so that note that I put there for IgE mediated, you can actually check that online too. And it came from URO, so that's where they mentioned it. And I also checked it. So oftentimes IgE stuff will be, type 1 hypersensitivity obviously has a lot to do with IgE because there's an allergen involved. But with this is not supposed to take long time, right? This is pretty quick. It's not going to be delayed. Type 4 is special because of the same stuff as type 1, but it's delayed. That's the major difference between type 1 and type 4. Right, so IgE gets mentioned in both places. 48. A 4-year-old boy has had fever, abdominal cramping, and repeated bloody mucoid stools with tenesmus over the past 3 days. Several other children at his daycare center have a similar illness. Direct microscopic exam of a methylene blue stained fecal smear shows neutrophils. Okay, so it's definitely bacterial. Which of the following is the most likely causal organism? So since they tell you bloody stool, right, from microbiology you got to remember which ones cause bloody stool and which ones don't. If you did sketchy micro, then bloody stool had people sitting on a red stool. So if you look at all these answer choices, someone getting abdominal cramping and bloody stool for 3 days, and then a lot of other kids also having it, that sounds like Shigella, and that's it. It's a really straightforward question in that manner. Can't pick E. coli because of the stain they told you. So methylene blue stained fecal smear revealed numerous neutrophils but not any organisms. Shigella is colorless when stained with methylene blue. E. coli actually stains blue with methylene blue because it ferments lactose. So when they did the methylene blue stain and all they saw were neutrophils, you know that it's Shigella. Shigella hides. E. coli doesn't hide. E. coli would be very evident. You would see it. Shigella causes an inflammatory diarrhea, produces a toxin that can invade tissues directly, and it's resistant to acids, so it has a very low infective dose. Like even if you just have 10 organisms, you're going to get full-blown bloody diarrhea. Tenesmus, the word they used here, tenesmus over the past 3 days, tenesmus refers to cramping rectal pain. Tenesmus gives you the feeling that you need to have a bowel movement, even if you already have had one. When you have tenesmus, you might strain harder to produce a small amount of stool during bowel movement. And tenesmus is pretty specific to Shigella. Right, so if you see tenesmus, that also helps you figure out that, this entire description of tenesmus, when you see that, it helps you figure out that this patient has Shigella. So other than that, you were really just between Shigella and E. coli. The others don't necessarily cause bloody diarrhea, and E. coli would stain blue. So they didn't see any E. coli. And they couldn't see Shigella because it doesn't stain blue. Right. 49. A 35-year-old man comes to the physician because of a 2-month history of inflamed, thickened skin covered with silvery scales on the scalp, trunk, elbows, and knees. This condition has been poorly responsive to coal tar preparations, calcipotriene, and triamcinolone. Which of the following drugs is the most appropriate next step in treatment? Okay, so 2-month history of inflamed, thickened skin. Thickened skin with silvery scales is a description of psoriasis. Psoriasis has thick skin. And then it's everywhere, so that also helps you understand it is psoriasis. And then they gave you a bunch of treatments that they used that didn't help because those treatments don't necessarily work against psoriasis. Psoriasis is kind of cancerous looking, right? It looks like your skin is having cancer in a sense. And that's how I remember methotrexate. Methotrexate would be a drug of choice for psoriasis, refractory to topical creams and light therapy. Inhibits dihydrofolate reductase in order to decrease skin cell proliferation and reduce inflammatory response. Calcipotriene, the one that they used, is a vitamin D analog that inhibits keratinocyte differentiation. Ustekinumab is a monoclonal antibody that stops CD4 differentiation and helps you treat psoriasis. And etanercept is a decoy interception that can also help treat severe plaque-type psoriasis. So calcipotriene was the only psoriasis thing they used, but it's not really good for intense psoriasis the way this guy has. It's everywhere. It's everywhere. Right? Silverase goes in scalp, trunk, elbows, knees. Like, are you really gonna put that this skin cream all over your body like that? Like, it's gonna be too much. Right? Cyclophosphamide is for bladder cancer. Azathioprine is for other stuff. Tetracycline doesn't help you with any of these things at all. It's an antibiotic. And tretinoin cream is for acne. So, you can knock out all these answer choices very easily. You just got to make sure you know what you're talking about. It takes time. It's not something that comes really easily. But, this is the end of the second block right now. And each block only really had like 2 questions that I could have possibly gotten wrong if I was taking NBME 20. So you want to make sure you thought about the questions the way I did. You want to make sure you focus on the things that I've been pointing out. Don't get lost by extra information. When you have questions like this where they tell you minimal information, this is harder than the questions where they have a big ass paragraph, because the big ass paragraph was supposed to be an easy question, but they made it harder by throwing a shit ton of information at you. Right? This question is probably not that bad either. So this one says 62-year-old man, alcohol-induced liver disease, develops massive ascites. Ascites is a really big deal, right? Ascites means that something is wrong with the sinusoids of the liver itself. You will never have ascites in a patient who has a pre-sinusoidal issue, right? That's something you want to make sure you learn more about if you don't know what I'm talking about. So post-sinusoidal or sinusoidal issues will have ascites. If it's something pre-sinusoidal, something that's not wrong with the liver per se, there won't be ascites. They ruled out infection. The most appropriate diuretic treatment, in addition to loop diuretics, includes which of the following drugs? Okay, so 62-year-old alcohol-induced liver disease. Remember what happens with liver disease? You start turning into a woman in a sense, right? You start getting the boobs and everything. So as soon as you start thinking of that, you can start discussing using spironolactone, and that's it, right? Clinical use of potassium-sparing diuretics, hyperaldosteronism, potassium depletion, heart failure, hepatic ascites, nephrogenic DI, anti-androgenic. Patients with hepatic ascites have hyperaldosteronism because the intravascular volume is escaped to the third space, which is what's causing the ascites. So adding spironolactone is a good choice. All right, and spironolactone is actually a really big deal. But if you discuss, we're at page 422. All right, let's take a look at what I was talking about. 422. So spironolactone you can look at whenever you want, but spironolactone helps here because remember, symptoms like gynecomastia, spiroangiomata, hypogonadism, and pulmonary edema are due to excessive estrogen. His liver is no longer getting rid of the estrogen, so he has this physical appearance now, looking like this, like a pregnant lady, right? And that's pretty bad, so you have to give them spironolactone. Spironolactone is going to be really good for them. It's anti-androgenic, and it helps them with the hyperaldosteronism, which is the main issue. So that's the end of block 2. Tomorrow at noon, I'll get on live again to continue on and go into block 3. Thanks a lot for joining, guys. I hope I can keep helping, and feel free to reach out to me through email anytime.